lengths we go to prevent those parts of ourselves from being seen? And at what cost? In this episode, we explore the tension between the threat of being exposed and the very human desire to be seen and loved just as one is.
I'm gonna skip us ahead to one of the stories.
I am an attending physician in advanced heart failure and transplant cardiology. I'm also a mom. I have 2 daughters. I consider myself to be a tough person, tough physically, tough emotionally, and tough mentally. But even so, I had an unbelievably difficult time trying to manage new motherhood with fellowship. One of the things that was the hardest was trying to figure out how to breastfeed and pump and work and kind of keep all that hidden, because it's not something that other people at work want to hear about. They don't want to hear about your boobs and your, sore, cracked nipples and all the things that go into trying to feed a human. One time when I came back after maternity leave, I was the cath lab fellow, and in between cases, I would try and run to the pumping room and pump. It was down the hall from the cath lab, and it was a shared sort of pumping space where there were chairs that were like sticky and gross, and there was like a little curtain you could get some sort of pseudo privacy in, and sort of strangely, it was also used as a surgery resident call room. So there was like poor surgery residents passed out post call there, and then there was this like social worker who had to use it as her office as well, which was insane. But I was pumping after a case once, and it's such a vulnerable position you're in, right? Like if you haven't done it, it might not be obvious, but you have to like take your shirt off at work and take your bra off and hook your boobs up to a machine. It's like a pretty intimate thing to do while you're at work. Anyway, so I was doing that. My pager went off and it said, urgent, Mr. So-and-so is bleeding from his leg. It had a patient I had just finished cathing, and it was femoral arterial access. So it's, pretty emergent if someone's bleeding from their groin. And I was hooked up to this machine topless. So I whipped the pumps off, threw my shirt on, left everything as it was, and ran down the hall. And I ran to the, post side of the cath lab where this patient was, and there was a nurse there who was standing over his groin with the bloody dressing that was visibly bleeding. And so I took over and held pressure. And as I was holding pressure, I noticed this patient was staring at my chest. And I looked down and realized that because I had left sort of mid-pump, my breast, which I have no control over, had continued to leak milk. And so there was milk like pooling in my scrub top through my bra. And it was just like the most humiliating thing to be standing there trying to seem professional, as a woman in cardiology, a woman in the cath lab, a trainee, to be standing there with milk leaking out of my breast. It was awful. And after the leg stopped bleeding, I went back to try and quickly clean up in between cases, because actually the next patient was already on the table and they were asking me to come in, and I lied and said I had to go to the bathroom, which is somehow more acceptable than saying I have to go clean up my pump parts. Anyways, I went back to that shared call room, and there was a note that someone had left on the chair that I had been in that said, "This is gross. This is a shared space. Please clean up after yourself." And I was just broken in that moment. I just wanted to scream, I am fucking trying so hard, and I can't win. I can't do it all. And it was one of those moments that I think all new moms have, where you just feel like, even if it's not true, you feel like no matter how hard you try, no matter what you do, you are just never enough. And it sucks. It sucks. And I am not alone in this experience. I know that every mom who tries to come, or who does come back and work or not after they've had a baby, has story after story after story of the difficulties and struggles of new motherhood, which are mostly invisible and mostly silent. One of my best friends was a structural interventional cardiology fellow when she had her second baby, her daughter. And so she spent most of her time in the OR, and she was also trying to breastfeed and pump, and there was no space for her to pump that was close enough to the OR. She could have come back to the stinky shared surgery call room that I was using, but it was too far and she couldn't. So she looked around, and what she found was a supply closet where they kept like a backup ECMO machine, which is like a, heart-lung bypass machine that's used for emergencies. And so she told me that she, in between cases, would go to the supply closet and kind of like clean off the top of the ECMO machine and lay her pump parts out and take her shirt off and pump. Sort of weirdly, it was also a space where people left their white coats to be laundered, like their dirty white coats. They would put them there, and then someone would come and take them to the laundromat or whatever. And so while she was pumping, like kind of crouched next to this ECMO machine, surgeons would open the door and throw their dirty laundry like at her, kind of inadvertently. And if that's not an apt metaphor for new motherhood, I don't know what is. You put your shirt back on, you swallow your pride, you bury your shame, and you go and you scrub for the next case.
Right. The whole series is filled with stories, that are evocative like that and thought-provoking and emotion-generating. So really recommend giving it a listen. We're going to get your reflections on that in just a moment. Before I do that, I want to just take a moment to define shame as we're going to be talking about it. It's important to be on the same page when we use this term, because it's a term that's often misunderstood, conflated with other related emotions, and finding some definitional clarity is really helpful when working with something so complex. So the way that we define shame is really pulls from multiple disciplines into one definition, and we're gonna acknowledge up front that this is a bit of a narrow definition, and we're going to broaden it in a moment. But think of shame as an emotional state or experience, often in response to a triggering event, but not necessarily always, in which we feel about ourselves globally flawed, deficient, or unworthy. Okay, it's a global negative assessment of the self, and that the pervasive feeling is that fundamentally there's something wrong with us. Okay, I'll define this further in a moment, but the other thing I want to highlight now is that when we feel shame, and many scholars would argue, we always, if not often, feel or perceive a sense of negative judgment from other people. And that could be people who are actually around us, looking at us, judging us, or it could be people that our imaginations are projecting. If there was a person over there, this is what they would see. This is how they would feel about me. And that what they would see and what they would feel would be a globally negative judgment of who we are. Okay, so shame often brings with it the experience of potent exposure, of being, judged, and then of feelings of being flawed, deficient, or unworthy. Now, we also work with a kind of a concept that we call the shame umbrella, and this is really meant to broaden away from just a narrow definition like this of shame to one that it encompasses various ways of potentially experiencing this emotion. And so there are kind of a set of adjectives or synonyms here that can be captured under the experience of shame that some might relate more to. So whether that's being, losing face, being ridiculed or humiliated, feeling rejected or inferior. What we would argue is, common among each of these terms is that there is a global negative, sense of the self here, and often if not always, a perception of negative judgment. Okay, so what we want to do now is just take a moment to gather a little bit of input from you. And so if you're on a computer, the web browser is easier, or you can just do your iPhone. It's also simple with the QR code. If you get asked your name at the beginning, just leave it blank and bypass that. This is really meant to be anonymous, so you can safely share. So I'm going to give you just a moment to kind of pull that up, if you will. You probably won't be able to answer a question yet until I toggle over. So just sit tight for a sec. And maybe someone could put that in the chat, that address in the chat.
Yeah, I did that. Well, so
excellent.
There's a link in the chat. Yep.
Okay, perfect. Thanks. All right, so I'm going to switch over. You'll still be able to use the QR code. It'll be on the other site in just a moment. All right. And then we'll ask a couple of initial questions here. All right, first question is a word cloud. So ideally 1, max 2 words. How did that story or the 2 stories you heard, how did it make you feel? What are your reactions to that? And feel free to respond more than once. All right. Obviously evocative. And there's a bit of a range of emotions here from, sort of anger, frustration, enraged. I mean, I'm not, obviously, I have two children. I could never experience anything like this as a man in society. And I find myself frustrated and angry about it. So I can't imagine people that, especially contemplating motherhood one day, someone I think put in there scared to be a mother one day, to have to confront these some of the stigma and these structural realities in which we live. Disgusted, weird, uncomfortable. Yeah, I mean, I really appreciate uncomfortable. I think we're working with uncomfortable experiences here, and I think it's worth reflecting on why they're uncomfortable as opposed to just biological. Right? There is a level of discomfort, or a certain way of feeling about processes and functions of the body that are layered on the way that society views them or sees them. Great, sympathetic in here. Yeah, I just want to, like tell her it's okay, hug her. I wish she was my patient, and I would have that opportunity to really delve into this experience with her. Okay, good. So this is an evocative experience, and when we're working with the body and the way that the body interacts with social structures around it, it is an evocative thing. As a patient yourself, have you ever experienced shame? And I think this is important because while we might be talking about this from the perspective of people who are delivering or could deliver healthcare, all of us are recipients of healthcare as well. And at various courses in our lives, we may or may not have experienced this emotion. Okay, so we've asked the question of have you experienced shame many, many, many times in many groups. We haven't asked it that many times in this way. If you're the patient, have you felt this? And the few times that we have, it's been a very similar distribution, right? The vast majority of people have felt this as a result of, during receiving healthcare, and many people don't know, somewhat because maybe the concept of shame hasn't been really clarified. So this is a common experience, though, among this group, and it's among all the groups we do this work with. So here's another word cloud. What has caused you to feel shame as a patient if you have felt that? So what is it about those encounters or your experiences that led you to feel negatively judged or lesser than or inferior? All right, this is great. And thank you for sharing and being open. And Luna will be talking about, you'll really be bridging a lot of these concepts when you talk in a little bit. I mean, there's a lot here. There's a lot of ways to feel shame as a patient or as a person in a body. And some of these things are, things that can be measured objectively, like weight, or the presence or absence of a disease. If we were to ask 70 or 80-year-olds this question, we might see a bit of a different list. Some of the terminology we use, heart failure or testosterone deficiency, just the terms themselves can imply that there's something wrong with us for having them, that we've done something wrong. Also a lot about how we're treated, whether we're dismissed or, that's is in here multiple times. Exposure, so nudity. I've had some experiences. I remember being in college, having a sensitive issue and having to undress in front of a young female resident at the time and just feeling so uncomfortable and ashamed just from the exposure itself. And it had nothing to do with her reaction to me. It was just her presence. The presence of stigma, we'll be talking a lot about that. So this is a really rich list here. And there's a lot to think about. I think this is why we're talking about this, because there are so many ways to experience this emotion. And so the question then becomes, how do we acknowledge that and then and think about it more deeply and become more aware of its potential, and what do we do about that? All right, so we'll come back for a few more questions in just a bit. I want to just focus us in on the second part around standards and norms. Anytime we're working with shame, we are in the presence of standards and norms and ideals, because many leading theorists around these emotions would say that that they most often come about when we transgress or fail to achieve a norm or a standard that's been set out for us, either that we've set out for ourselves or that society has dictated for us, our parents, our loved ones, etc. So one of the most potent shame experiences I've ever had was when I hurt a patient as a resident, caused a bad error that really hurt a patient. And I experienced crushing shame from that because I've transgressed the predominant standard of medicine, which is first do no harm. And falling short of that standard led me to feel and see myself in certain ways. Okay, so shame often results from the failure to reach a standard or a norm. So you can't talk about shame without considering the role of standards and norms. And shame often alerts us to the presence of those standards and norms. When we feel shame, as I've sort of alluded to already, we attribute the failure to reach one of those standards, the transgression against a norm, to something about us, the whole person, right? A global deficiency of the self. And so the self-talk of shame often sounds something like, I'm lazy and I'm weak. So take the good example is someone who's struggling to quit smoking. Okay, and coming in to talk to your doctor about having to quit smoking can be rough because you often know what they're going to say. You know you shouldn't be doing it. You know it's not good for you, and you're doing it anyway. Okay, and that is a tension that many patients bring into our encounters with them. A shame response to the failure to quit smoking might be I'm lazy and I'm weak. I'm not strong enough. There's something wrong with me. Guilt, on the other hand, is an emotion that occurs when we fail to reach a standard, but rather than blaming the whole self, we blame something we're doing, a behavior, a circumstance, an action that we've taken, something that's modifiable, that might be deeply entrenched, but that we can theoretically change, right? So I'm struggling to quit. You know, I'm not lazy, I'm just struggling to quit. Quitting is the action here that I'm having a hard time with. I keep buying cigarettes. That's why I keep smoking. I'm keep being around people who are smoking, or I keep going out and socializing, and that's when I want to smoke. Nicotine is addictive. Sometimes the reason for the failure of the standard has nothing to do with us at all. It might have something to do with the world around us. Okay, so guilt is an attribution to a circumstance or an action. And what's really powerful about this distinction is that when we feel guilt and we also practice self-compassion, we are naturally oriented to try and fix those things that we see as deficient, that theoretically can be changed. So guilt tends to be a more constructive, pro-engagement emotion, whereas shame tends to invoke some defensive posturing, some self-protective measures, and often a desire to kind of hide, shut down, and withdraw. And Luna's going to talk more about the response to shame in just a bit. Okay, the reason this matters, well, it matters for a lot of reasons. I think one of the biggest reasons that we do so much work with shame in healthcare, among some other fields, is that healthcare is absolutely just loaded with standards and norms. I mean, for everybody, for patients, for clinicians, for administrators, it is such a standards and norms driven discipline. And that means that we are constantly navigating a set of expectations and ideals against which we can compare ourselves all the time. Every single day in my practice, I have an opportunity to fall short of some standard. Many days I do, and most days I achieve them, right? But that balance is often in flux. Patients are constantly navigating standards and norms. What's also important to note is that healthcare in many ways is a reflection of society. It's an institution and a discipline through which a lot of social forces flow, through which a lot of social norms and standards are codified and then maintained and upheld, and then become fodder for comparison as we navigate healthcare environments. Okay, so this is a particularly potent area where we find social norms and structures filtering down to the level of the self. And Luna's going to talk more about that too. I think last year, the year before, it was like when ChatGPT was kind of just revving up. I asked it to generate an image of what is it like. I said navigating a bunch of rules and norms and standards, and this is what it gave me, and this is what it came up with. It's the person navigating it. And if you've ever navigated the norms and standards of a highly sort of ideals-driven space, it can really be brutal. I mean, especially if you constantly assess yourself as falling short of those standards. What can often happen is you begin to really question and lose a deeper sense of self, and we know that can happen with shame. Okay, so let's just do a little bit more pull everywhere and get your take briefly on some of those norms and standards. So if you can just jump back over to where you were, I'm going to jump back over, and you'll again have the QR in a second. All right, so the next question I want to ask you all is, what defines the ideal body? Okay, so if there are norms and standards that dictate what is sort of a body should be, what are those ideals? And I think actually this might be let me see if this is a word cloud or not. I can't remember how I created this. Okay, so this is not a word cloud. You can type as long as you want. You can use as many words as you like. As this list gets populated, you can also upvote. Let's not downvote, but upvote any that really resonate with you. I'm not going to be able to keep up with this as they populate, but you'll be able to scroll up and down, seeing what other people wrote. Okay, and I'm gonna push you guys on this. What defines healthy? Okay, so if healthy is an ideal, what defines that? Think about some specific standards and norms that help comprise the ideal body. Okay, a lot here about stature, weight, sources, TikTok, social media. I mean, when I was growing up, it was magazines, TV shows, etc. I think social media, none of us can escape now. Society has a lot to say about this. I would challenge you to think, how does society communicate those norms? Barbie, one of the classic standards, right? Which has gone through the kind of the ringer over the years of saying, is Barbie inclusive of all bodies, deeming it to be not, and then still producing the same Barbie figures every time. Great. A lot here around things around economic class. And Luna's going to talk about determinants of health and how shame can be a determinant of health. Mobility, ableism, or ability, I should say, which can drive ableism. Great. Confidence, popularity, capitalism this is really rich. Famous people. Okay, so we're living in a society that clearly, and if we did a word cloud, many of these would be really big, that has some strong ways of communicating these standards and then upholds these standards. Okay. All right, I think the next question we can skip because it was just from where these arise, which we've kind of gotten already. So Luna, I'm going to turn it over to you now to jump over to the next section.
Oh, you're muted, Luna.
Just realized, sorry. Um, so we've been talking about shame so far, and I'm just going to say a couple more things about shame that Will hasn't already highlighted. But um, in social theory, shame actually stands out above and beyond other emotions as uniquely significant for human life. And I think this is really important when we're thinking like, why are we talking about shame in the body rather than guilt in the body or anger in the body or any other emotion? But shame has been called the master emotion. It's really centrally connected to how we are in community with others. People talk about shame as the glue that holds society together, because folded into every shame experience is a norm or a standard that tells us what is appropriate or not appropriate or right or wrong, good or bad. And through these experiences of shame, we learn how to fit in, how to like do the things that will make us accepted and stay in our social group. And the evolutionary psychologists say we've evolved the capacity for these self-conscious emotions like shame and embarrassment, to keep us in the fold so we don't get like ostracized and thrown out of our social group, because we need to be in a social group to survive. So it's like the emotion of survival. As a result, it's like a really primal emotion. It's not rational, it's not reasonable. And often we will do things that are like really irrational or seem really irrational, really unreasonable to protect ourselves from shame. And this is really important when we're thinking about healthcare and how shame might show up in a healthcare context. So what we experience shame as a personal failing. It's like a hugely individualizing emotion. When we have this emotion, we think, oh, I've done something wrong, there's something bad with me. But often shame is actually very, very deeply connected to social norms, as Will was highlighting in when we were talking about what constitutes an ideal body. There are all these like social norms that are pushing on us, determining how we should be or what we think we should be. And the other thing to say is that shame is taboo and a difficult emotion, and I think we all know that it's sometimes even shameful to admit to shame. So to admit that you experience shame leads to further shame. And what happens as a result is it becomes deeply buried and often goes underground. So we individually ignore shame. We don't want to admit to it. We often deny that it's happening. We lie about it. And then we do that collectively as well. So this is something that's affecting us all in different ways, but we're often not talking about it or openly acknowledging it. So how is this relevant for healthcare? Well, I'm going to talk a little bit about some of the themes that in this article that's on the slide, health-related shame and affective determinant of health, to talk about how shame can show up in healthcare and the effect it can have as a result. Let me see if I can let me see if I can read that. So shame is so pervasive, so corrosive of the self, and so potentially detrimental to health that there is considerable utility in considering it as an affective determinant of health. So when I wrote that paper with my colleague Barry, who's an anesthetist, that was the kind of central idea that we were positing is this really central emotion to human experience so important that we should consider it a determinant of health separate from social determinants of health or cultural determinants of health. And if you're not familiar with that concept, like a social determinant of health would be something that's within society, which is affecting the health outcomes of an individual. So some of the common ones might be things like socioeconomic status. If you're living in poverty, you're going to have poorer health outcomes. If you're marginalized or stigmatized in any way, that will lead to poorer health outcomes as well. So is there something worthwhile in thinking about shame itself as a determinant of health? So there's lots of evidence about stigma and health outcomes, and there's a little bit of evidence about shame and health outcomes. But in general, the research that there is demonstrates that shame and experiences of shame can lead to poorer health outcomes. And these are just some examples from the literature. And there are various mechanisms that make this the case. And I'm going to go through three different types of factors that influence how shame can affect health. So I'm going to talk about acute shame avoidance behavior, and I'll define all of these terms as I go through chronic shame avoidance behavior and talk about the relationship between stigma and shame and social status threat and how these impact on the body and impact as a result on health and also on social outcomes and our overall life chances. So thinking first about acute shame avoidance behavior. So when I use the term acute shame, what I'm talking about is like what's often called an episodic emotion. It's an emotion, a reaction that happens as a result of a discrete event. So acute shame might arise like if my trousers fall down while I'm lecturing, I will be acutely ashamed, and that will be an emotion that arises, has a certain duration, and then passes away, and it's connected to a particular circumstance or an event that's happened. And usually acute shame is connected to exposure. So something happens where we feel the self is exposed. So that could be the physical body, like nudity is a huge form of exposure, or a violation of privacy, like someone overhears something that you'd rather that they didn't overhear. And Irving Goffman, who's a Canadian sociologist who wrote a lot about how emotions regulate social life. He writes, exposure can interrupt movement, bind speech, and make eye contact intolerable. Shame paralyzes the self. So the phenomenology of this experience of acute shame is that, and you might have experienced this yourself, is like you kind of sort of freeze and shut down. It's like you want to hide, and that image of the head in the hands is very common when people are depicting what this feels like. You might feel hyper visible or really conspicuous, like everyone can see your flaws and they know what you know what you did or what's wrong with you or what's bad. So acute shame can be a really disruptive experience and a really acute and distressing experience. As a result, we go to great lengths to avoid it. And this is why people talk about shame as regulating social behavior, because we all learn the things that might make us feel shame or acute shame. And then we also learn how to avoid them. So we keep our clothes on, we don't behave inappropriately, et cetera, et cetera. But there are these moments where the exposure can't be avoided. Because acute shame can be so difficult, we will do everything to keep a lid on it. And we will hide things that we think might make acute shame arise. So if we're worried about judgment, we're worried about what people think about us, and we're worried about the gaze of the other, then we will keep things kind of tamped down so we can try and pretend that there's nothing to worry about. And this is really common. So this collective and individual suppressing of shame, denial of shame. So there's a psychiatrist called Donald Nathanson who devised something called the shame compass, where he talks about how our experience of shame is so difficult, we will go to great lengths to avoid it. And we've got common patterns of behavior that we go to in order to bypass our shame. So sometimes we hide it. And we do that just through withdrawing from a situation or avoiding a situation or just not disclosing or maybe lying or not telling, everything accurately. Sometimes we lash out at others, so we feel shame or embarrassed, and the way we cope with that is by lashing out, and that can lead to anger or defensiveness or blaming someone else. And sometimes we have compensatory behaviors like Brene Brown, if you know her work, she talks about perfectionism quite a lot. And the way she defines perfectionism is by saying, well, perfectionism is actually just trying to stay two steps ahead of shame. So behaviors like perfectionism, overachievement, overcompensating can also be a shame, a way to bypass shame or to defend the self from shame. So in healthcare contexts, this is important because these behaviors can show up in a clinical space. So I have done this, not for any big reasons, but I have lied to doctors if they've asked me questions that I didn't feel comfortable. And I think probably most people have, like maybe not fully lied, but maybe not completely disclosed. How many glasses of wine a week do you drink? So it's very common for us to try and defend ourselves from negative judgment, especially when we perceive an imbalance in power relationship. So especially in a healthcare context, the doctor is the authority, the professional, the expert, the one who can pass judgment. And in fact, that's actually what their job is, to pass judgment and scrutinize. So these protections from shame can show up really clearly in the clinical behavior, in clinical encounter. So some of the examples that we see here might show up in patients and some might show up in physicians. Will, is this a poll everywhere?
No.
No, okay. But these are questions we can ask. So how might bypass shame show up in patients? Well, I think we've done a lot of research in the NHS. I should have said this. We collected a lot of data from patients about how they've experienced negative self-conscious emotions in clinical encounters. And some of the reporting we've had are things like, I will never go back to that doctor because I felt shame in the encounter with them, or I felt they were shaming me. So avoidance, withdrawal. I couldn't tell the truth. So like lying or not complete disclosing. Self-blame, so feeling to blame for some perceived inadequacy in an encounter. Getting angry and defensive with doctors is also the case. And then in physicians, all of the same behaviors, withdrawing, maybe leaving the profession, getting angry or defensive. So what's really interesting when you start to use the shame compass is that there's a lot of different types of behavior, like from perfectionism to lying to anger to defensiveness, that are all driven by the common experience, which is feeling shame, feeling a fear of negative judgments, maybe feeling like social bonds are threatened, that you might be rejected or ostracized. And so once you start to use the shame lens and use the shame compass, you start to see the kind of common experience behind a range of outward behaviors. So there was a study, very interestingly, there's a lot of research about health-related stigma, but very little research about health-related shame. Um, so in a study by Harrison Darby, they asked the question to patients about shame in clinical encounters. So half the patients reported that they had an interaction with a physician that caused shame. And I should say we've done a lot of empirical research as well of researching shame. It's a very difficult thing to research. People don't disclose shame. They might not want to report it. They might lie about it. They might not realize they were experiencing it in the moment. So this number could well be higher. Um, sorry. And as a result of this experience of shame, 72 patients said they lied to the physician about their health-related behaviors. 73 patients avoided seeing the physician again, and 91 patients said they stopped seeing the physician. So you can see there's like a really concrete effect that is the result of shame coming up in the clinical encounter. And we can explain this because, as I said before, we will go to great lengths to avoid shame, and we will do things even that seem completely irrational or unreasonable. In our data, we have patients saying, I'm actually concerned I have cancer, but I've decided to never go back to the doctor because I don't want to experience shame again. So it's like the fear of serious illness is trumped by the fear of experiencing shame again from a healthcare provider. So thinking about chronic shame avoidance behavior, and there's a very important difference between acute, what's often called acute shame, this episodic emotion that arises as a result of a particular incident, and what is called chronic shame in the psychology and psychotherapeutic literature. And this is where shame becomes a kind of disposition or a way of being as a result of experiences like chronic disadvantage, chronic discrimination, trauma, relational trauma, where there's a relationship set up with a broader society where an individual feels that there's something flawed or wrong with them, even if that's not conscious, and that drives the sort of behavior that they live with. So if you're interested in chronic shame, there's an amazing book by a psychotherapist called Patricia DeYoung called Understanding and Treating Chronic Shame, and I really recommend it. So chronic shame, just to quote here, involves recurring or persistent shame that forms a background of social pain and self-consciousness. Feminist scholars have called it an affective attunement, and it colors all aspects of one life. So I think it's fair to say most women live with chronic body shame, with something that's kind of present in some way in most of your experiences, a kind of self-consciousness and a sort of social pain that forms a background of life, but becomes kind of like so normal and common sense that you just think that's just the way things are, or that's just the way I am. So chronic shame can also lead to this experience of shame avoidance. And so many of the, as I said, the things that cause chronic shame, like relational trauma, minority stigma, psychopathologies, so things like body dysmorphic disorder, PTSD is also a cause of chronic shame, etc. And that is very much related to stigma and social status threats. So when people live with stigma, so whether that's stigma as a result of identity or because of illness, often chronic shame becomes part of their experience. So stigma and shame are related, but they are not the same thing. And this is one of the things that's been very interesting in looking at shame in healthcare is trying to disentangle these two concepts. So stigma is usually thought of as a negative belief that society has about a person because of unfair or unjust social norms. So when someone lives with stigma, they kind of live with, it's a category term. It's like a label that's put onto a person to say there's something deviant or different or flawed. And often stigma is connected to illness, it's connected to bodies, it's connected to circumstances. And sometimes stigma is very much connected to health. So we have this concept in health literature called health-related stigma. So things like HIV would carry stigma. Certain types of cancer carry quite a lot of stigma, like lung cancer, where there's a perceived sense of like personal inadequacy led you to have this. Maybe you're a smoker. Obviously, lung cancer is not necessarily related to smoking, but health-related stigma can be a really powerful factor in one's health experience and also one's health outcomes. So there's lots of literature that shows that if you live with stigma, your health outcomes will be poorer, and also your circumstances will be compromised. So your life chances are also compromised. Now, I'd really like to point out that stigma and shame aren't exactly the same thing. So when we live with stigma, we live with this kind of label, and the affective or emotional side of that is shame or negative self-conscious experiences where we feel that we're being judged by society to be less than or flawed, or we're not living up to the ideals or standards that we feel like the ideal healthy individual is. So stigma and health-related stigma leads to behaviors like hiding, disengagement, powerlessness, loss of agency, threatened identity, disenfranchisement. And the kind of affective link here is shame. So stigma isn't something we experience directly. What we experience are stigma-related behaviors, like we might experience discrimination or labeling or minoritization or mistreatment or unfair treatment. And the emotional or affective component of that is often a type of shame experience, whether it's embarrassment or feeling disrespected or feeling like you're being treated as though you're worth less than others. And then that, of course, can lead to these other behaviors. I'm going to hand it back to Will to ask another question through Poll Everywhere. Shall I stop sharing there?
Yeah, great.
Yeah, cool.
All right, yeah, so we're gonna ask two quick questions and get your reflections on this. First is just if and this, there'll be some overlap maybe with what we put before, but if you could just write down in a word cloud some of the conditions that carry stigma with it. And I would encourage you to respond more than once if you can. All right, I think we keep this coming. I think we've got I think we have time. I'm just going to open it up to the group, and I would encourage you to just raise your hand. Let's do that just so I can kind of call on you. Raise your hand, and or use the chat. What do people, can anybody just offer any reflections on this list? Like why? There's some things that jump out at me when I look at this list about these being stigmatized conditions. So I'll leave it kind of open-ended. What jumps out at you? Why are some of these stigmatized and or what about these conditions is notable that there's stigma surrounding them?
I mean, they're associated with some sort of negative health outcome. I don't know if that's too simple, but they're all like conditions that involve some degree of suffering, or at least, if not suffering, the stigma would cause suffering.
Great. Yeah. So these are impactful health outcomes. I mean, or impactful conditions that have impactful health outcomes, right? That also may position people in society in certain ways. The outcome itself could do that, whether it's disability or carrying a stigmatizing condition, being infectious, et cetera, so that the impact of the disease itself could only amplify the stigma around it. Okay, what else? Kim, you had something you were going to say?
Yeah, I realized that Venus said something quite
Yeah,
similar to what I was thinking in the chat, right? That many of these thinking of things like obesity, diabetes, AIDS, are perceived as preventable. So it's sort of the result of someone's like quote unquote bad behavior in some way, is the I think common perception of some of these conditions.
great. Yeah, so not only perceived as preventable, but seen as maybe the result of a behavior or an action, and therefore the fault of a person. Great. Yeah, Vinny, you were saying the same thing. Other Kim. Yeah, also just the stigma that surrounds some of the conditions themselves, the words, the conversations that have to be had around them. I train resident doctors and students, but particularly with residents, and it's kind of incredible how often I have to say, you really need to go back there and do a rectal exam right now, right? Or why didn't you do a speculum exam to take a look at the inside of the vagina? And it's often because they're just uncomfortable. It can feel like a violation. It can make them uncomfortable. It's often the projection of their own discomfort that they assume the patient will also experience. The problem is if you're a patient and you're feeling like your doctor's uncomfortable with something about your body, it's easy for you to then think, should I be uncomfortable? He or she or they are uncomfortable, right? So that's these sensitive topics and sensitive areas of the body are ripe for them to become stigmatized, often through our own discomfort.
Can I jump in and say something? So
Yeah.
there's a political philosopher called Martha Nussbaum who's written a lot about stigma and shame, particularly in the context of criminal justice. And she said something that was really insightful to me, but she said, what we define as stigmatizing or stigma, we want to put stigma on or shameful, we always do that in contrast to our own vulnerabilities. So things like sex and death and mortality and the things that make us feel vulnerable are the things that we then project the shame and stigma onto. And it's a kind of type of projection where it's like the badness is out there, it's not in me, and I'm going to protect myself by saying you've got the stigma. But it's very much connected to like our human vulnerabilities, that we're frail animals that will die. We're sexual beings with desires and emotions. And those are the things that then societally we put the shame and stigma onto. And you can see that in this list as well.
Great. That's a really good point. What else? What other people think? I just want to point a couple of things out here that just the existence of them that I think are really significant. Menstrual being a part of this, right? So
Mhm.
that's different than some of these other ones. That's a reality of human existence. If you have female organs, right? That menstruating is going to be a part of that existence. Or, for most it will be. Another is addiction. That's a big one. Another here is lung cancer. I've had patients that have lung cancer and have never smoked a cigarette in their life, and they feel a ton of stigma around having lung cancer, even though there wasn't ever a behavior that led to it. Any thoughts about any of those or any of the other ones you see on here? Yeah, so Benjamin, thanks. What you're describing are kind of extensions of the just manifestations of shame, right? That there's something about me that is wrong or broken, unlovable, unworthy, etc. Luna, you were going to comment on that?
Well, I was going to just chime in on the gendered element, like menstruation. So there's a lot of feminist literature about how the ideal body in society and then in medicine is the male body. So anything that deviates from the male body, like pregnancy, menstruation, menopause, is stigmatized. And I mean, until recently, pregnancy was a taboo thing. You wouldn't go out if you were showing. That was like Demi Moore posing in the 90s, nude and pregnant, broke that taboo massively. But until then, it was actually something that was quite shameful to be seen to be pregnant. So the gender dimension is huge, I think, when we think about how shame lands on different bodies.
Yeah, and then that gender dimension is many would argue just the propagation of social structures that position women as less powerful or in a lesser position. These are not biological realities. These are social structures that have sort of propagated biological differences over generations of people. But it filters down at the level of feeling shame because you're having a menstrual cycle or having to talk about that with your physician, right? So it's shame is one of those emotions that really, and I think Charlotte, you made the point, gets transferred very easily. It can move, right? And it can move across dimensions down to people. It can move among people, and the body can become a medium through which a lot of that movement can occur. Yeah. Yeah, Ken, okay, thank you for that too. Yeah, so there's also some sort of normal ways for some of these conditions to present. That's a really great point. And if you're outside of some of those normal quote unquote presentations, first of all, that can be very hard for a patient because your experience as a patient can be dismissed very easily because you don't fit the mold of that condition. But it can also feel very isolating. Yes, and also there are dominant sort of ways in which certain conditions are understood and seen, typically through white bodies, right? When you look at the history of medicine, that skin, for example, skin conditions, the majority of education, of textbooks, et cetera, teach skin conditions on white skin, and that's how it's learned. And so there's inherent sort of structural racism that manifests itself at the level of the patient and the doctor, because the doctor may not have ever been trained to identify something on colored skin, or skin of color. So, yeah, that's a really important point. That even within a stigmatized condition, there can be different additional levels of stigma depending on how it's experienced. Yeah, Michael's, you summarized that really well. I failed at being ill. I'm presenting abnormally. And sometimes I find myself as a doctor saying, this is your condition is such a fascinating case. And I have to be careful saying that. You know, I found myself catching myself saying that doesn't quite sound right. All right, Petra, last couple comments here. Please keep them coming. I'm going to turn it back over to Luna to kind of take us home. We're going to ask one more quick question that'll segue to the next one, which is the concept of shaming, causing another person to feel shame. Should we ever use it to drive behavior change? If you think about some of these conditions on the slide before, should we ever use shame to try to avoid the occurrence of those conditions, whether that be lung cancer because of smoking, acquiring a sexually transmitted infection, so on and so forth? Yeah, I mean, maybe this needs to be Global Classrooms Part 2 for us, because this would be
Yeah.
this would be an awesome thing to discuss and debate as a group. Luna's going to provide an opinion on this, but there's clearly some mixed opinions here about this, and we thought a lot about this topic as well. Okay, great, Luna. I'm going to turn it back over to you.
Yeah, I'll just start sharing again. Yeah, and just to close the session, we're going to reflect on this question of whether shaming should ever be used. I'll continue to share. Hopefully that's visible. Shaming should be used as a tool. And I should say it is used as a tool. It's used in criminal justice contexts as punishment. Sometimes, for instance, people who receive DUIs or shoplifting charges will get a shaming punishment. So instead of paying a fine or serving time, you might end up standing in front of a Walmart with an A-frame strapped to you that says, "I am a thief, I stole from this shop." Or you might get your paper printed in a newspaper identifying you as someone who has a DUI charge. It's used in healthcare contexts, in public health interventions, where a lot of people have thought using negative emotions like shame and guilt and remorse can motivate behavior change. So if you're shamed for smoking, that might motivate you to change your behavior and quit smoking. So it is an open question. And when you look at the research and the literature, there's evidence on both sides. So some people really vehemently argue that shaming is an effective tool, and others will suggest that it's never appropriate to use. So I'm going to present some of those ideas, and then we can consider it. So there's this book by Jennifer Jackett, Is Shame Necessary? New Uses for an Old Tool. She's actually talking about the use of shame primarily in environmental campaigns. So she gives a really great example, I think, of the shaming campaign in the 80s towards tuna fishing companies to stop them from killing dolphins. So when people realized that like tuna fishing nets were inadvertently were catching dolphins and causing a lot of dolphin death, there was like a concerted shaming campaign against these companies, which led to the introduction of a quality mark. So you could see like dolphin safe tuna. And that was a really effective use of shaming against corporations. And what she argues in the book, in a kind of muddy way, but she does say that actually this is actually a very effective tool when we're shaming big entities like nation states. Like if you want to shame a country for a war crime, or for mistreating women, or if you want to shame a corporation for bad employment practices or for killing dolphins, it can't, because reputation is such a powerful motivator for behavior change. It can lead to action, but it's very different to do that than to shame individuals. So there's a distinction made by an Australian criminologist called John Braithwaite, and he's talking about criminal justice context, the difference between reintegrative and disintegrative shaming. And he thinks when shaming is reintegrative, and he draws from examples from Maori culture in New Zealand, where someone is shamed because they've done something that's at odds with the norms of the community, say they shoplifted. You might use shaming to teach them a lesson, to point out their bad behavior, make them an example, but then it will be a reintegrative experience if they're brought back into the fold. So they're back in the community. And I think I'm a parent, and maybe some of you are, but when you inadvertently shame your kid, that's the idea, is like you still love them, they're still part of the family, they're back in the fold, but they've learned their lesson. Whereas disintegrative shaming, or sometimes called stigmatizing shaming, is when someone is shamed and then they're like chucked out of the community. They're not brought back into the fold. They can't rehabilitate themselves. There's no opportunity to come back and be part of the group again. And Braithwaite argues that, well, if shaming is used in this reintegrative way, where it hurts, but a lesson is learned, but you're still part of the group, then it can be effective. But the question is whether you can rely on strategies to make it reintegrative versus disintegrative. So there are people working in public health that argue that shame is a useful tool. And I give this example. Daniel Callahan is probably a kind of well-known example of this. But he talks about anti-smoking campaigns and his own experience. And I'll read from this quote: "As a smoker, I was first criticized for my nasty habit, and eventually, along with all the others, sent outside to smoke, and my cigarette taxes were constantly raised." He says, "The force of being shamed and beat upon socially was as persuasive for me to stop smoking as the threats to my health." So he's saying, actually, being shamed and having smoking stigmatized and leading to this kind of, ostracizing behavior, shaming behavior, was really effective. It helped me quit. And this is the rationale that's used in a lot of public health campaigns. So just put a couple examples here that are actually mobilizing shame or shaming in order to motivate behavior change. So the one on the left is a COVID campaign from the UK. So you might recognize it if you were in the UK during COVID. It was the Look Them in the Eyes campaign. And here you've got the kind of judgmental, shaming, guilting gaze of a sick patient with COVID. It's kind of an accusatory thing. So tell her you never bent the rules, implying that you probably have bent the rules, and this person is accusing you. And the one on the right is an childhood anti-obesity campaign. Essentially, what you can see there, it's hard to be a little girl if you're not. It's quite shaming message there, but with the idea that it's going to motivate, I assume parental behavior change. And in the UK, it was interesting during COVID, the UK government and Public Health England were being advised by behavioral economists who really advocated for the use of negative emotions in public health messaging. So all our campaigns during COVID were shaming, essentially all of them. And actually, the evidence showed after that they weren't effective as a result. There's a book by Alexander Brewis and Amber Wutich, which is here, Lazy, Crazy, and Disgusting, it's called. They are medical anthropologists in Arizona, and they did a big review of global health campaigns and looked at stigma and shame in global public health. And they look at lazy is obesity, crazy is mental health, and disgusting are hygiene campaigns. So those are the three big areas they look at. And basically what they determined is that any campaign that traded on stigma or shame to motivate behavior change was not effective. They were like targeting individual behavior change. And often what happened is the shame and stigma that was mobilized by these campaigns would just entrench bad behavior. So people would get defensive. They would like double down on the thing they were supposed to do. You want me to quit smoking? I'm going to keep smoking and do more of it. So it actually like largely backfired. And so for individuals like Daniel Callahan, who are probably, well, I assume he's an academic living with white privilege, male privilege, and the privilege of being a middle-class academic, maybe shame will work. Maybe that will be a message that says, you know what, I should change my behavior. For people who maybe don't have such a secure social position or lower down a social hierarchy, it's going to land very differently. And this is why it's not just me who argues this. Purposeful shaming is not effective. There's quite a lot of evidence in the criminal justice literature and the public health literature that it doesn't work because its effects are unpredictable. It often doesn't lead to positive or pro-social behavior change. Maybe it'll work for 50% of people, maybe, but then that 50% that it doesn't work for means that we shouldn't do it. If it's not working, if you're mobilizing it across a population, then you want to be sure it's working for everyone. And if it's not working for everyone, then it's not an effective tool. So shaming can lead to defensiveness or entrenched antisocial patterns. There's plenty of evidence for that. It can lead to stigma, scapegoating, or othering. And this is a really important point and something that we saw a lot in COVID. So in the UK, the government were a bit hopeless and they were constantly pointing the finger at different groups. So it's like students in Freshers Week are having parties. That's why COVID's spreading. Multi-generational ethnic households are spreading COVID. And they were constantly pointing the finger at different groups who were supposedly spreading the virus. But when they were doing, what it meant was that it condoned everyone else doing it. So it led to these massive pylons where certain groups were being scapegoated and blamed because the government or a public body was doing that. So when shaming comes from a public body or from officials or from government or from a hospital, then that can condone this kind of othering and scapegoating. And I think we see that a lot in contemporary politics. So shaming can cause harm, especially to populations already living with stigma, trauma, shame, or marginalization. And we've seen this around health and health outcomes. And of course, it can reduce dignity and feelings of belonging and worthiness. And if dignity is a basic human right and we want to promote dignity for everyone, then we shouldn't be mobilizing shame in any context. And there are other ways to motivate behavior change. And sometimes it's hard to think of what they are, but I'll just offer a couple of examples of like a COVID campaign that doesn't rely on shame, but relies on connection, belonging, togetherness. A food campaign that isn't about shaming, but is about, joy and being a champ. So there are ways to motivate behavior change that will lean on things like connection and togetherness and belonging, which are often seen as the opposite of shame experiences. So the challenge is, of course, how to move away from shame and towards more positive affect. But I would argue that it's not really appropriate to use shame on purpose, and we should try and find other ways to motivate people to be healthier or follow the law or do other things. So I'm not sure if that's the last slide. Will, do you want to take over?
Yeah, and we'll just leave. You can click
running
these
out
in a
of time.
moment. But I'll just maybe add one other thing. One of the places where I work a lot with shaming is within educational settings. And in some healthcare settings and educational settings, shaming is thought to be a necessary pedagogy. I need to help you remember to never do this again by first making you feel a certain way about it. And often the point I want to make here is that you might see the behavior change you're looking for when you attempt to shame someone, and it might be more than 50% of people, and you might think this is successful. What you won't see is all the collateral from the shaming episode, right? Because we naturally try to hide or repress our shame or keep it behind closed doors, and yet there can be profound suffering. So we have to first, before we ever consider using shame, we really have to say, is there a better way? And I would argue that for the vast majority of us, what we're going to do with our lives, there's always a better way, right? And it's especially true in working with patients, vulnerable populations, learners, et cetera. So, three key takeaways, and then we'll wrap up for the day. The first is just to practice, awareness of shame. This is an emotion that can feel very wrong. It can feel very uncomfortable. And in the way that I've kind of come to really wrap my head around it, especially spending a career working with it, is that it also proves that you're just a human with an intact, self-evaluative mechanism. And so being more aware of the potential for shame, especially in the society in which we live, and especially in the standards and norms-driven professions that we're entering or trying to enter, is really important. And then if you combine that with authentic concern for other people, we have to behave differently. The second key takeaway is just we would advise avoiding shaming. If we can all find ways to have the impact that we want to have as people, as professionals, without shaming, that should be the goal. And then I think maybe another time, or maybe for some of your follow-up discussions, is what could some of those alternatives be? Guilt may be one of those. Can we leverage guilt by maybe directing people towards actions and circumstances that they can change and away from sort of damaging self-evaluation? And then thirdly and finally is just be mindful of the presence of bypass shame. If someone's acting towards you in a way that is defensive, is angry, is seemingly shameless, it's like they should be feeling worse about themselves and they're not. Pause and think about the possibility that they could be dealing with something at a deeper, more fundamental level that they might not be able to deal with in the way that you deal with yourself or would hope, and to just take a moment and sort of breathe and not react to that behavior, and sort of react with more compassion and empathy. All right, with that, we're at 12:15 exactly. Thanks for having us. Luna, will you put that back up just so they can have
Oh, sorry.
the website and our emails? Feel free to reach out. We will maybe see some of you on another session, but thanks for being a great group.